Okay, ladies and gentlemen, let's move to the next agenda. Is presentation from Ms. Niketut Kumala Dewi Haryadi, MSN APRN AGNP from Cleveland Clinic, Ohio, USA, from nursing field, and with continue presentation by Mr. Professor Samar Ahmed, Associate Dean Academic Affairs at Dubai Medical College. And this presentation will be led by Mrs. Mumpuni M. Biomed. But before, let me read the curriculum vitae of Ms. Mumpuni. So Ms. Mumpuni, she is a lecturer at Poltekkes Health of Science Jakarta 1, as well as she is head of nursery department in Health Poltekkes Jakarta 1. She graduated from Faculty of Medicine University Indonesia in biomedical program, major in physiology in 2008. Without any further ado, for Mrs. Mumpuni, time is yours. Good morning, everyone. Is my voice heard? Ulang. Good morning, everyone. May I have your attention because the second session is about to begin. Assalamualaikum warahmatullahi wabarakatuh. The honorable speaker and the respectable audiences from all over Indonesia and overseas, thank you for coming virtually in Jakarta, Indonesia. First of all, let us thank to Almighty Allah Subhanahu wa Ta'ala because of His blessing, we can gather here virtually to join this international seminar. Ladies and gentlemen, the presentation of the second session is about the cardiovascular medical tools in nursing, and the second is about interprofessional education and role in integration of technology in health. And this session we'll conduct in panel discussion. So allow me to introduce the first panelist. The first panelist in the session is Niketut Kumala Dewi Haryadi, MSN, APRN, AGNP from Cleveland, Ohio, Ohio Clinic, USA. And the second panelist is Professor Samar Ahmed, Associate Dean Academic Affairs of Dubai Medical College. Before we start the session, I would like to read the rule of the session. I'd like to convey the rules. The audience can give the question to chat box or straight to raise hand to the speaker. Well, ladies and gentlemen, moving along to the presentation, we give the first panelists to Miss Dewi. Let me read the profile. Miss Dewi, with the education background, as a medical doctor in August 2007, Associate of Applied Science in Nursing in 2014, Bachelor of Science in Nursing in 2015, and Master of Science in Nursing in 2018. Please scroll. And the professional experience of Ms. Dewi is in Cleveland Clinic Independent Family Health Center, primary care nurse practitioner, and Cleveland Clinic Fairview Hospital as a staff registered nurse, medical surgical stroke and epilepsy unit. And scroll. Lanjut, Mas. Terus. And the clinical experience, Ms. Dewi is nurse practitioner student experience, summary of skills, Independence Village and Bloom. In 2018,
Beria Alzheimer Care Center and Aristocrat in 2018, Premier Physician Internal Medicine in 2018, Fairview Hospital Cleveland Clinic Internal Medicine in 2017, KSU Midtown Foot and Ankle Clinic in 2017, and much more. For the other clinical experience, Ms. Dewi is internship experience in Jakarta, summary of skills, and experience from the professional field is General Hospital Bekasi, Department of Labor, Budi Asi General Hospital, Tarakan General Hospital, Mampang Public Health Center. Practice as a medical doctor, I think, yeah. For award and honors, there's a few. The latest is member Sigma Theta Tau International until 2014. And research experience, healthcare reform, utilization of patient-centered electronic health record, education and prevention of cervical cancer adolescents, association between serum transaminase and dengue shock syndrome in children. Continue. Yeah. That's I think that's the curriculum vitae and profile of Miss Dewi. And we come to the second panelist of this panel. The second panelist is the Professor Samar Ahmed, founding director of Famer Fellowship and Health Professions Education. Yeah. Scroll. Professor Samar.
Yes, excuse me.
Yeah.
I can't open my.
I read the experience first. As Assistant Secretary General of the Supreme Council of Foreign University Egypt, Associate Editor Education Subsection Frontier, Chair of the Center of Excellence Educational Psychology, and many more. Yeah. And the latest as Director Quality Assurance Unit ASU FTM. The education background of Professor Samar is American Board and Fellowship in Health Professions Education, Fellow for FAMER or Foundation for Advancements of International Medical Education and Research in Philadelphia for the year 2011. Doctorate degree in Forensic and Toxicology Ain Shams University in 2006. Postdoctor in Health Profession Education from FAMER. Certified Trainer UNESCO Board for Bioethics in 2010. And I think I can read all. Master's degree in Forensic and Toxicology Ain Shams University in 2002. Scroll.
Nyambung lagi ya saya?
Yep. I think I'll read the latest activities of the Professor Samar. Yeah, teaching and training within the strategic planning activities and in the Faculty of Medicine, Director and PI at the Newton Musharrafah Institutional Link Project Live. Scroll. Yep, many more. Stop. Yeah. Project proposal written and awarded. Project for Faculty of Medicine Ain Shams University Development and Preparation for Accreditation. Applying for fund and applying for fund of 10 million LA from Council of Higher Ministry of in Egypt. a combined ethics and communication skills, curriculum development, and allied international approach, and many, many more. There's a long list of the professor experience. And the latest is membership in professional bodies, Worldwide Association of Women Forensic Experts, Educational for Health, the Network Toward Unity for Health, Association of Medical Education in Europe, World Federation of Medical Education, Foundation for Advancement of International Medical Education and Research. I think there's a long list of broad experience from Professor Samar. Miss Dewi, how are you? Are you with me?
Good. How are you?
Nice to see you again.
Yes, nice seeing you guys. Thank you so much for giving me the opportunity to give the
For all the
presentations today.
speakers, I think the first panelist will be delivered the presentation, and then after the Miss Dewi, we will give the opportunity for Professor Samar. Before we start the presentation, let us begin with Basmalah. Bismillahirrahmanirrahim. Miss Dewi, you have time to deliver your presentation about 40 minutes, please.
Okay, thank you. So I would like to share my screen here. Good morning, everyone. Thank you so much for attending the seminar.
Good night, Miss Dewi.
Thank you, Tante Ria.
Okay.
So let me see here. Are you guys able to see my screen?
No.
No? Okay, thank you. Okay, thank you so much. I'm sorry about not able to. Okay, so today I would like to present regarding the cardiovascular medical tools in nursing. Next slides, please. The objective about this presentation is to increase the awareness of medical technology device for early detection of cardiovascular disease and to promote standard practice for nurses on using cardiac medical devices to improve quality of care and patient outcomes. Next slide, please. So heart disease represents the major causes of morbidity and mortality worldwide. Sorry, can you hear me?
Ditambah volume suaranya.
Can you hear me
Yes,
now?
we can hear you.
Okay. So the early detections of heart disease by using various medical devices is one of the key to delay or prevent the morbid events. Preventions of serious cardiac events can increase the life expectancy significantly. And the most common cardiac devices that use to early detections of heart disease are electrocardiogram, ambulatory heart monitor, stress echocardiogram, cardiac CT scan, and cardiac MRI. Next slide, please. So electrocardiogram. Electrocardiogram is a painless, non-invasive device to record electrical signals in the heart. The EKG may also be used to detect abnormal heart rhythms, block or narrow arteries in the heart, like atherosclerosis, and whether you have had previous heart attack, heart failure, or heart damage. Next slides. And for the electrocardiogram instructions, I'm sure you guys already have experience on how to use the electrocardiograms. So if the moderator able to click on the short video to show it. to open the link. Is it able to or no? The link on, yep, that one.
An EKG is a simple and painless We use an EKG to detect any heart problems such as a heart attack, irregular heartbeats, or heart failure. With each heartbeat, an electrical signal travels from the top of the heart to the bottom of the heart, causing the heart to contract and pump blood. This signal creates the rhythm of the heartbeat. Okay, I'm going to have you have a seat right up here.
All right.
And today we're going to be doing an electrocardiogram, also known as an EKG. Have you had one of those tests before?
No.
No? Okay. So this test is going to measure the electrical activity in your heart. We'll show how fast your heart is beating, if you have a regular or an irregular pulse, and it'll show us the electrical activity in each part of your heart. There are many reasons why a patient may need an EKG. Your doctor will normally order one as part of your routine physical. If you were to complain of chest pain, an irregular heartbeat, or a fluttering in your chest, if you were to have shortness of breath, weakness, fatigue, your doctor may also order an EKG at that time. There may be also other reasons, such as a strong family history of heart disease with your mother, father, sister, or brother. Your doctor may also order an EKG if you are on heart medications or have a pacemaker. So we're going to go ahead and get started on your EKG. I'm going to have you lie back, and I'm going to bring this out for your legs. All right, and just relax. Are you comfortable lying like that for a few minutes?
Yes.
Okay, I'm going to have you undo your gown so I can see your chest. I'm going to place electrodes across your chest, on your arms, and on your legs. The electrodes are just small, sticky tabs that'll be placed over your body. Sometimes when men have a lot of hair on their chest, we will need to remove that hair so that the adhesive sticks better to the skin. There are about 10 to 12 electrodes on normal EKGs. I'm going to roll up your pant leg just a little bit, okay?
Yes.
Okay, just relax. Now I'm going to take these leads and hook them to the electrodes. That's what's going to create that electrical activity to show up on my EKG machine. And it'll show up on a grid on the piece of paper, or it can also show up on a screen for the doctor to read.
All right.
Okay, I need you to lie real still. Try not to move too much and try not to talk. This will just take a couple seconds. Okay, that was it. Now I'm just going to remove these leads and the electrodes. I won't be able to give you any results. You will need to follow up with your doctor, and he'll be able to go over those results with you.
All right, thank you.
Thank you for the video. So we can go back to the slides now. So that's how they're
have to
performing
know
the
the
EKG.
endpoint. And trust me, you got.
I'm sorry. So that's how to perform the EKG. Like you seen on the video, the nurses will explain the procedures to the patients first before performing the EKG and ask the patients to remove all the metallic objects, electrical equipment, to undress from the waist up and expose their ankles. And the patient will lie down on the stretchers. And as the nurses mentions, if the patient has excess hair, it's necessary to remove the excess hair so the leads can attach properly, and you probably need to use alcohol solution to disinfect the area. After you place the EKG electrode, like the nurse is showing in the video, the nurse will ask the patient not to move and speak during the test. So we will have the good EKG result without that many artifacts, because when the patient moves too much, it will produce the artifacts. And once we check all the EKG, ensure every lead is seen and not many artifacts, they can remove the EKG. And on those pictures is the positions of the leads on the EKG. Okay, next slides. So the second one is the ambulatory Holter monitor. This is like the heart monitor. So usually we order this monitor when the patients complain like palpitations, like arrhythmia or heart rhythm abnormalities. So EKG is just reflecting your electrical activity at that moment. So if we're not able to capture the activity at that moment, that's why we need the Holter monitor. So the Holter monitor is usually is an ambulatory continuous EKG that will record your heart activity, the electrical activity in your heart within 24 or 48 hours. So the patients, when they're using the Holter monitor, they can continue to do the regular activities, but they cannot shower or have full baths within that 24 or 48 hours, have an X-ray, stand near a high voltage area, or stand near the metal detector. When the patient's wearing the Holter monitor, they will be given also the diary, like the book diary, to record whenever they have like symptoms, like let's say they have like a chest pain or shortness of breath or like a DC, those kind of thing. They need to press the monitor whenever they have symptoms and then record it on their event diary. So once the patient completed with the Holter monitor for 24 or 48 hours, usually they will bring the recorder back to the office, to the doctor office to get removed, and the doctors will read the Holter monitor result and also the event diary that related with it. Next slide, please. The other event monitor or heart monitoring is called Zio patch. So Zio patch is usually its order when the patients have heart arrhythmia or heart palpitations, but the event is not every day. So let's say the patient says, I have been having palpitations, but it's once a month or a couple times in a week, those kind of things. So usually the doctor will order this Zio patch. The Zio patch is the recorder, is a small water-resistant heart monitor that continuously records your heartbeat for up to 14 days. This test is indicated for patients who may suffer from transient symptoms such as palpitation, syncope, dizziness, or lightheadedness. The same thing with the Holter monitor. When the patient is wearing a Zio patch, like you see on the pictures, they will put it on the left upper chest. They need to press the button whenever they have the symptoms. and then they have to record it. They will also give an even diary to record what they're doing when they have the palpitation. Let's say I have heart palpitations when I'm walking my dog or when I brush my hair. So they have to record that. And then once they're done wearing the monitor for 14 days, they need to mail back that Zio monitor to the mailbox. So it's actually it looks like this, but with the return envelope already. So they will just need to mail it back whenever they're done. Okay, and then on this next slide, it's showing the Zio instructions and how to use it on the left upper chest. The next test is a stress echocardiogram. So this is this test is ordered a lot by the doctors whenever the patients have chest pain and the patient comes to the office having arrhythmia, shortness of breath, feeling lightheadedness and dizziness. And the doctors want to know if this is like angina or some things that we worry about. So the stress, the first one is exercise stress test. Exercise stress test is often involves walking on treadmill or riding a stationary bike while the heart is being monitored. The exercise stress test will help to reveal how the heart is responding to physical activity, whether the heart disease symptoms occurs during this exercise. So it's usually the patients, they will have the patients wearing the electrodes first, and they will check the patient's heart activity when during rest, and they will have the patients to go to the riding the bike or the treadmill, and they will record also the heart activity during that time. And then echocardiogram is the test that producing moving images that show how well your heart functions under stress. These images allow your provider to see structure and functions of your heart or ejection fractions, assessment of the valves, like the shape, size, and motion of your heart valves. In order to prepare the patients for exercise stress tests and echocardiogram, the nurses, this task is usually performed by our cardiologist nurse. The nurses need to prepare their patients and remind the patients to avoid caffeine and not taking their beta blocker medications 24 hours prior to the test. And to NPO or fasting 4 hours before the test. Why they have to fasting? Just in case when during the test it's showing abnormality, they will go straight to the cath lab. Okay. And then the other things, the nurses need to remind the patients to wear comfortable clothes and shoes, stop smoking or using tobacco products that day. If the patient unable to do exercise stress test because, let's say, they have some knee pain, this kind of thing, or because of their age, the physicians or the provider will order the pharmacological stress test. This test is using medications including dobutamine and vasodilators to produce the stress to the heart. Dobutamine medications will increase the heart rate, and the vasodilator expands the blood vessel, which increases the blood flow through the heart. So that's the pictures of the stress test. And then the next slide is regarding the cardiac medical device. The other cardiac medical device that also ordered by the providers usually is cardiac CAT scan and cardiac MRI. The cardiac CAT scan is a procedure that utilize multiple X-ray beams from different angles to acquire 3D images of your heart, along with the blood vessels and surrounding structure. The cardiac CAT scan is indicated to check plaques buildup in the arteries, assess heart valves, aorta aneurysms or dissections, assess congenital heart disease, and mass or tumor around the heart. And then the last one is the cardiac MRI. So cardiac MRI will use this powerful magnetic field, radio waves, and a computer to produce detailed pictures of the structure within and around the heart. The cardiac MRI will detect and monitor cardiac disease, assess the structure and functions of the heart muscles. So I think that's the end of my presentations. Thank you so much for giving me the opportunity to give these presentations. And if you have any questions, I will be more than happy to answer it. Or you can also send me an email for any questions that not answered today to my email address, haryat.n2@ccf.org. Thank you.
Thank you very much for the excellent presentation from Ms. Dewi. For the audience, if you want to give answer a question to the speakers, please put in the chat box, or you can raise hand you straight to the speakers.
Thank you.
Ms. Dewi, maybe from me first, yeah.
Sure.
For administering the procedures, is only the responsible for of the nurse, or only responsibility only for the doctor?
They administer the procedures of which one?
The echocardiography.
So the echocardiogram is performed by our echocardiogram technologists for that one. So when they performing the stress echocardiograms, there need to be the cardiology nurses, needs to be echocardiogram technologists, and needs to be cardiologists present during the test. Just in case if the patient's having a chest pain, shortness of breath, the cardiologist nurses needs to be ACLS, certifies the advanced cardiac license certifications, to be able to perform these tests.
How about the nursing students? They are able to running the administration of this procedure to the patient?
Unfortunately not, because like I mentioned, it needs to be a special nurses. It's a cardiology nurse, and it needs to be ACLS certified as well.
Is it even under supervision from the professional nurse? They cannot do that.
Yeah, I haven't seen one that they allow the nursing students to, probably if they want to watch, for the procedures being done. Like I'm personally also just watching what they're doing for this performing stress test and echocardiogram as well. But they're the ones that will attach the electrode. They are the ones that's gonna inject the medications, the contrast definitely if the echocardiograms is not capturing the heart good having a good picture for the heart, or they are the one that also administering the dobutamine or the vasodilators.
Is there any new update of procedure for the patient who are running operation or surgical? The same procedure for the patient who want to running operating? Is both procedure can be administered in the patient who wants to go to the operating room as usual?
I'm sorry, I don't think I understand this question. So do you mean that they still can run and then go to the surgery cath lab right away?
Yeah.
Yes.
Mm-hmm. And about another procedure of cath lab, is it responsible for nurse responsible too?
The nurses will be standby also over there, but it's going to be the cardiologist, interventional cardiologist, the one that performing.
Okay, thank you, Ms. Lee. Maybe from the audience, we invite your participation, please.
Excuse me.
Yes.
Yes, moderator.
Hello.
Miss Henny,
Hello,
please.
see you.
Nice to
See you
see you.
again, Miss Ketut.
Yes, nice to see you again.
Yeah. I want to know about the ECG for the mobile, especially for the emergency situation. They always use only one or two cable, of course. Your experiences in America, of course, or others clinic, is this graphic from ECG make more any possibility for diagnosis, especially for the clarity in for the two or staff in mobile intervention. Result from diagram ECG, it's only two. How they can use this diagram for the intervention. They use just
When
only two,
they
yeah?
are using two leads, you mean when they are using two leads, how they use
Yeah. For
how
the
they
priority, how to resolve the problem for the client.
how to resolve the problem of the client if they only do the two leads EKG.
Yes.
Okay,
I,
that's a
I
good,
feel curiosity.
yeah, that's a good question. I don't think I'm certain about the answer about that questions because the one that we have been doing, I work in internal medicine ambulatory. We have been doing 12 lead EKG all the times,
Yes.
you know, to in order
Yes.
to you know, read like what's the patient's, if the patient is having ischemia or not at that point, you know, and then probably ordering the next steps, which is usually the stress test, you know. So I haven't had any experience about just two leads in, but I
Yes.
understand like in like a certain situations, emergencies, probably they're not able to
Yeah.
perform the 12 leads EKG.
But of course, the better for the research is only 12, not
Yes.
only two. Yeah, is that right? I feel curiosity for the staff in mobile, how
Yeah.
they put intervention for only two.
Right. Exactly. Yeah. Mm-hmm.
Yeah. Thank
Thank you
you,
for the
Miss.
questions.
Great.
Thank you, and great
Thank
seeing you again.
Thank you, Miss Uni.
Thank you, Bu Henny, for your question.
Any other questions?
We're still waiting for another participation.
Don't be scared. I don't bite.
Maybe you can tell your experience and involving to the other professions beside nursing who prepare the procedure. Maybe what is the difference between preparation running by nursing or running by doctor for the procedure?
For which procedure? I'm sorry.
For both procedure, ECG or echocardiography.
Okay. So I think for the doctors or the providers, of course, they're not performing the EKG itself. They will only put the order of the test, you know, and then all the procedures in here. To be honest, in the US, EKG most likely is performed by our medical technologies or our medical assistant. it's not even by the nurse in here. So some of the nurse still do, but most of the time the EKG is performed by our medical assistant in the ambulatory setting or also in patients. The doctors not performing any EKG at all, they only read the result, about the EKG.
Okay. And how about the interpretation of ACG electrocardiography? Is only responsible for only
The
the
doctors.
doctor responsible.
Whoever the provider.
Doctor
So
tell the result from the ECG.
yes. So yeah, so whoever ordered the EKG, either the doctors, the medical doctors, the nurse practitioner, the physician assistant, those are the providers in the United States that able to order the EKG or other tests. They only actually read the result and their interpretations and ordering the next steps, the next test in order to get better evaluations of the diagnosis.
Yeah. Another question for me about the training of advanced cardiovascular. Is it allowed in the United States for the nursing to have ACLS?
Yes. So the ACLS is basically just like skills. So in here, for all nurses, we are required to have basic life support, the BLS. And then on top of that, if you want to, like one of our nurses, the cardiology nurses, they just need to take the test also for the ACLS. In order to be able to work in special situation, special department like cardiology.
Thank you, Ms. Devi, for the explanation.
Thank you.
Okay. From the audience is still waiting for participation.
Thank you.
In Bahasa Indonesia, maybe you can raise your questions. Maybe we can help.
Sure.
Ibu Dewi is Indonesian. Are you
Yes.
still Indonesian or no? Still Indonesian or the American citizen now?
Yes. Unfortunately, I just switched to U.S. citizens recently. Yeah.
Okay.
But in heart, I'm still Indonesian 100%.
I'm still Bahasa Indonesia, right?
Yes, all the time. Yes.
So maybe the participation can participate in Bahasa Indonesia to give questions. Yeah.
Of course. Yes.
Please.
Hi, can I ask something?
Yes, please.
Yes.
So you mentioned about Ziopath.
Yes.
Ziopatch. So
yes.
When I was working in Indonesia, I know only about Holter, and normally we did Holter when there's a patient hospitalized. So the doctor gonna or the provider gonna order to do a Holter test on a patient. So it's gonna be like 24 hours period in hospitalized. But lately, I know that in Indonesia, even Holter can be done by a vendor. So you don't have to be hospitalized. So if you have a heart problem, like in case you got a chest pain and you go to your cardiologist, and he or she gonna perform Holter test to a patient, and you in case that patient doesn't want to hospitalize, So actually, they have a vendor that the vendor will go to the patient house to do the Holter test. But so far, I only know about that, and I'm interested to know about Zyopatch, and because I think in Indonesia we didn't have it yet.
Yes.
Thank you.
Thank you. Thank you for your questions. So the Holter monitors is ambulatory now, heart monitor. So the patients outpatient especially doesn't have to be stay, so the nurses usually will apply during their office visit. The nurses will apply the Holter monitor to the patients, and the patient can go home and then come back the next day. If it's ordered for 24 hours, come back to the next day to return the Holter monitors to the office. Or if it's 48 hours, same things, the nurses will apply the Holter monitors to patients, and then after 48 hours, they're gonna come back and then return the Holter monitors to the office. For the Zyopats, it's very convenient right now. So we have the Zyopats in stock in the office. So the patients will apply, the nurses will apply the Zyopats to the patients during their office visit, and then they can go home doing their normal activity. They can still shower. With Holter, you cannot shower. With the Zyo, you can shower because it's 14 days. It's kind of too long if you cannot shower, right? So after 14 days, because it's already, the box is already including with the return envelope, so you can just mail that Zyo patch to the mailbox that it's provided, the other options, if we don't have the Zyo monitor in stock in the office, what we usually do is we order that. So we put the order, and the iRhythms, the company that making the Zyo patch, will mail that to the patient's house. And then there is patient instructions that will guide step by step. It's very clear what to do on the how to apply the Holter monitor. So patient can perform it themselves, and then after they're done, since it's already have the written envelope on it, they can just mail it back. So it's very, very convenient for the patients. And we have a great results from it because it captures like many of our patients that are having a heart palpitation, SVT, those kind of things. So we can see how often they get that symptoms within that 14 days window, and if the medication is needed or not, depending on how frequent the episode is happening during that 14 days monitoring.
Thank you, Veda, for the question.
Thank you. I hope
you.
in the future, Indonesia able to have Zyo patch.
Yes, of course, yes. I think it's coming. Probably it's coming. Yes. Any other questions? Should I answer the questions from the chat?
Another question from Yeti. Yeah, from Yeti is okay. How to use the Holter monitor and to procedure, and what are the risks and contraindication for using these tools? Thank you, Yeti, for the questions. Yeti from nursing major in Poltekkes Jakarta.
So how to use the Holter monitors? I actually have the lists in here, So the patients, when they come to the hospital, they will be given this, the nurses will give this Holter, and attach it to the patients, they will come with the leads and also the monitors. So the nurses will put the leads, just like putting the leads for the EKG, and then they will connect the leads to the recorder, and then they will given also the pack to be able to carry it on their purse, on their pants, this kind of thing, the monitors, so it can capture the electrical activity during that for 24 or 48 hours. So far, the risk, I don't hear any risk that the patients have when they're using a Holter monitor or contraindications. But if some of the patients is very sensitive with like the electrode patch, they can get the skin irritation. The same thing with the Zio patch. The patients may get skin irritations from the band that comes with the Zio patch. So the patient need to let the nurses know if they have like a sensitive skin, to the packs.
Thank you, Ms. Lee, for the answers.
And the I'm sorry, the contraindications will be, you cannot, near the X-ray, like those kind of things. You cannot do showering because it will get loose easily. It will not record it, the activity that we needed.
Yes, of course.
Thank you.
Is coming another question from Ibu Heni. Do you think is it possible if the electrodes of the patient are integrated in 2 monitors, either in a nurse or in a doctor? Is it also possible when mobile on the Holter monitor? The electrodes of the patients are integrated in 2 monitors.
Either 2 monitors? Yeah. No, it's just 1 monitor. It's just 1 monitor, but when the result is sent to us, it can send to whoever the providers that order it, and we can always forward that results also to the other provider. But it's only using 1 monitor only.
Is it also possible when mobile for the patient?
Yes, they do encourage to be doing their daily activity. So that's why it's called ambulatory, because the patients, we would like to see what the patient is doing during that 24 hours. How is the heart activity, the electrical activity during that 24 hours? So they can still doing all the activities, but we do mention it to the patients usually to prevent strenuous exercise, because excessive sweating that they will have when they're doing strenuous exercise, that will have the risk of the pads or the electrode to be dislodged.
And do we still have a recording from the result from the administration? Do we have a recorded from the procedure? There's
yes.
No.
Yes. So the recorder, once the patient's done, the Holters, the recorder, once it's done, it's go back to our office, and then they will download that recorder, and then we will read the result.
Thank you, Ms. Dewi. There's another question straight from the MC.
Yes.
Ms. Anna, please.
Okay. Thank you, Ms. Niketut Haryadi, for your really great presentation. So,
thank you.
First of all, I'm not, my background is not a nurse, so maybe my question is a bit like, you need to explain more detail because unfortunately I don't really get into for some words. So I interest in Zio patch that you just show before. What is the indication for this Zio patch for? Is it for all of the patients that have cardio problems, or like when you will give it to the patients, for example, and then how you educate to the patient that make sure that device is function well and in which condition, something like that, because this one is will recording in 14 days, right? So and
Yes.
those recordings, is it like lifetime? I mean, directly connect to the nurse or to the to the clinician, or we just wait until 14 days, something like that. So can you explain more about this, because some my family also have a problem with this, so I'm interested with this Zayopatch.
Sure.
Thank you, Miss Nika.
Sure. Thank you. Thank you for your question. So yes, the Zyopatch is usually ordered when the patients have palpitations, like I mentioned, irregular heart rate. They usually come to our office. They mention, I have been having fast heartbeat. I've been feeling skip heartbeats, those kind of things. I've been feeling a little bit lightheaded, and my heart is pounding not right. Those kind of things usually. So we want to see what's going on. Do the patients have actually atrial fibrillations that it's just not captured during the EKG? Or do they have a fasting heartbeat like the SVT or PVC skip beats that is not captured during the EKG? So that's usually the indications. And we prefer this method compared to the Holter just because it's longer durations, 14 days. So especially if the patient says, this is not happen every day, so we kind of afraid if we don't order the Zyopatch, it's not capturing when the patients have the symptoms. So the longer duration is more convenience for us to capture, to see how the patients really, the heart rates during that 14 days, how often they get the PVC, how often they get SVT or the AFib. This kind of thing. And then what is your other questions? I'm sorry, I forgot about it.
Like how can you instruct to the patient, because the patient will go home, right? And then the caretaker, something like that. Yeah.
Yes. So the device will come with the patient instructions, like this. They can read all the instructions, what to do, what is you need to be cautious about. With the Zio, it's usually because the patients can still do the activity like normally, and then they can still take shower, they can still do everything. The only things that we try to mentioning to patients, do not do too much like strenuous exercise, like I mentioned before, just because the profuse sweating, of course, sometimes it may dislodge that patch that on the Zio. So, but other activity, if it's just moderate or mild exercise, just walking, this kind of thing, that shouldn't be a problem. And then it's also come with the books for recording the symptoms, what they're having, like in here, they mentioned. So what you having, and they have to press the button. Whenever they have that symptoms, they have to press the button. That's how we know, what are they doing, what activity is during that heart. During that event, so if are they having chest pain, are they having irregular beat, are they having lightheadedness, and what are they, how long is it last? Is it 1 minute? Is it 5 minutes? And what are they doing at that time? Are they just resting? Are they doing walking? Are they brushing their hair and they're feeling lightheaded? Those kinds of things. We would like to know that, because not every patient that come in our office with palpitation, we will prescribe beta blocker, so if they only have, like, let's say one fast heartbeat, one SVT, or a couple of SVT, of course, we will monitor, depend on how the patient's symptoms. We probably just mentioned, how is your caffeine intake? So make sure you don't drink too much caffeine that may causing the palpitations, those kind of things. But if they have frequent heartbeats, like like 20, 80, those kind of thing, of course, we're gonna prescribe the medications right away and order the next steps is usually the stress cycle.
Okay. So can I say, like, this one is a first observation, right? When the
Yes.
patient come. Okay. Thank you, Ms.
Yes.
Nika.
Thank you.
Thank you, Miss Anna, for the question, and Miss Devi for the remarkable answers. I
Thank
think
you.
it's the end of the presentation from your deliver. And maybe I can give a little conclusion. It's a little bit different in Indonesia because the medical technologies is administered all of the procedures is different from here because in Indonesia it is usually administered by the nurse. And the second is biopath can be recorded and the procedure have to be explained well to the patients and family to have a good preparation and have a good result. Thank you for Ms. Devi for remarkable presentation. We have maybe another
My
time
pleasure.
and see you again in Indonesia maybe.
My
Thank you.
pleasure. Thank you so much.
Yeah, thank you for coming virtually in Jakarta.
Thank you.
Here are the certificates from us as a great appreciation for this. Yeah.
Thank
On
you. Thank you
behalf-
so much.
On behalf of the director of Poltekkes Jakarta 1, we gave this certificate for you. Thank you very much for your remarkable answers and for sharing your experience. Thank you.
Thank you so much. I really appreciate for giving me the opportunity to give these presentations. Thank you, everyone.
Thank you.
Thank you very much.
Thank you, Tante Ria.
And Auntie Ria.
Thank you, Miss Ketut.
Auntie Ria. Thank you.
Okay, ladies and gentlemen, we come to the another panelist. The second panelist is Professor Samar Ahmed from Medical Education Dubai. Professor Samar, are you with us?
Not yet, Miss
We have
Nuni.
information before that she have an emergency call from the Ministry of Health Dubai. So she permission have maybe can start at 11. Not yet. IT, maybe you can share something to the audience. IT. Waiting for another panelist. Share something.
presentation.
Ya, selamat datang Pak Jaini, welcome.
Ladies and gentlemen, unfortunately, Professor Samar Ahmed cannot join us in this session. So we will continue with the next panelist. The speaker is Bapak Zaini Dahlan, SSIT, MPH. Thank you very much for coming, Mr. Zaini Dahlan. It's an emergency. We are very sorry.
That's okay.
Maybe
Thank you very much.
I can read your curriculum vitae. For education and training, Mr. Zaini Dahlan, Master in Public Health, School and Health Sciences, University of Wollongong, Australia in 2007. Bachelor of Applied Science in Dental Nurse Education, Faculty of Medicine, Gajah Mada University, Yogyakarta, Indonesia in 2002. Diplomatry of Dental Health Academy, Bandung, Indonesia in 2000. School for Dental Nurse, Tasikmalaya, Indonesia in 1991. Public-private partnership short course, University of Queensland, Australia, short-term Australia Award in 2016. The training program and certified care worker system for Indonesia, Japan in 2018. Working experience, maybe I read the last, yeah. Junior Policy Analyst, Ministry of Health, the Republic of Indonesia in 2022. For Mr. Zaini Dahlan, we give the opportunity for you to deliver your presentation. Are you with us? Are you ready for the presentation?
Yes, thank you. Please allow me to share my own screen for the presentation.
You have 30 minutes, Mr. Zaini.
Okay.
Yes.
Am I allowed to share my own presentation?
Yes, please.
Okay. Just a minute. Hang on. I think I need to share the sound as well. Hang on. Okay. Okay, can you guys see my screen?
Yes, it's clear. Yes, it's clear.
Okay, thank you very much. Well, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. First of all, I would like to thank the committee for inviting me. Initially, I was asked to, ask my colleagues in the Alliance of the ASEAN and Asia Pacific Oral Health to be one of your speakers today, but since my colleagues, who is Mr. William Jones, are not available for today's event, so allow me to represent our organization to be one of the speakers on this very important conference. Well, I would like to present a topic that I believe that all the audience, have been aware, and I think it is just a, refreshing or reminder for you guys how the technology, especially in the dental care, has been, developed, along the way this year. So I hope that my presentation is not boring and will be beneficial for us, and I hope also that it will inspire you guys, especially my colleagues in oral health therapy care field, to be more, motivated to develop and maybe just apply the recent technology in the oral health therapy care field. I would like to start my presentation with such an introduction, maybe, because not everybody, familiar with the term of the profession of dental therapist or oral health therapist. So, ladies and gentlemen, oral health therapist is actually a quite new terminology for in Indonesia. Maybe it used to be known as perawat gigi, but nowadays in international level, actually there is a expanded dental team. So beside dentists dental specialist dentists, there are some others profession which are the most known is actually dental hygienist, and then dental assistant, and also there is one profession that is called dental technologist or dental technician, and the last but not least is dental therapist. Actually, dental therapist has been evolved in 10 or 20 years after, actually it evolves because, the lack of, the dentist in many areas, in many countries. So I think what I'm hoping now is everybody would know what is dental therapist and what is oral health therapist actually. And in international level, the terminology or the nomenclature of dental nurse is no longer acknowledged, especially in UK. Maybe some of people just call dental assistant as dental nurse. And in 2018, some of the countries have agreed to form a organization, internal organization. We gathered in Malaysia at the time. I remember on the 6th of April 2019, if I'm not mistaken. So there were representatives from Australia, from New Zealand, from Fiji, from Malaysia, from Singapore, from UK, from South Africa, and from Indonesia, which was represented by your truly, myself. So we agreed to form a organization that is called International Oral Health Association that has mission, 6 mission. We can say it as miles. Our mission is, how to make a strong global advocacy for, oral health therapists, and we are willing to support each other in, developing our profession, and we hope that our organization can be a place to, transfer information and then lessen the burden of oral health disease in this world. And we are willing to also promote the excellence in the areas of clinical practice. And we hope also that we can provide, sustainability in good quality oral health services providing by oral health therapists in this world. And recently, because, the pandemic and so on, the IOHS is still in, hiatus or something like that. So 6 countries in the region, which is in the ASEAN region and Asia Pacific region, have had a meeting, and we agreed to collaborate and made another alliance, another organization, which is called the ASEAN and Asia Pacific Orahat Alliance. And the objectives of our alliance are, number one is actively support each other in CPD events, and then actively collaborate and support the development of the area of dental therapy, oral therapy, and dental hygiene. And we have signed a memorandum of understanding, consists of 6 countries, which are, New Zealand, Australia, Fiji, Singapore, Malaysia, and Indonesia. And we agreed that the definition of oral health therapist is an oral health therapist is qualified into important roles. So terapis gigi dan mulut or oral health therapist has dual qualification, which are dental therapists and dental hygienists. That means that all oral health therapists could provide diagnosis, treatment, advice, and preventive programs for the oral health children and adults. So oral health therapists has, competencies and scope of practice in, clinical practice from diagnosis to treatment that is limited in, prevention and oral health promotion, especially. Okay, ladies and gentlemen, let's talk about the technology, or maybe you can call it health aids or something like that. We already are aware that in the past, our practice is, rather unsafe, painful, uncomfortable, and it makes, some of you get, dental anxiety or dental fear. So that's why the technology has been developing to be more safe, less painful and comfortable, and more important is satisfying. It is important. That we are going to talk about that, why we need a technology. You know what? In the past, the technology generally is translated into something mechanical. But nowadays, as you may have been aware, that when we talk about the technology, it also, talking about digitalization. So it's inevitable for us to master, to be aware that in this era, when we are talking about technology, so we have to be more concerned about the development of digital technology. Okay, ladies and gentlemen, I would like to share with you the 8 principles of development and application of the technology. The number 1 of the principles is when we are willing to invent something, or we develop technology or application or something else like that, we need to focus on the person, because we are the provider of care provider to human being. So number 1 principle is the technology should be person-centered technology, because the technology that we use is for humankind or human being. The second is we have to think about, integration. So I think in this day, it is rather useless when we, develop a technology that is fragmented or separated. We must think about, the development of an integrated technological. And when we talk about that, we need to think about, the building an ecosystem of the technology. And number three is autonomous and informed choice. Because we care about human being, our service is, about providing healthcare for human. So we need to make it secure and, private, confidential. So when we develop, something like electronic medical record or something, we have to concern about the, secure and safe data. Number four is how we protect the data that we gather in this application or something. And we also have to consider that we need to apply the inclusiveness in the technology, in the digital and health literacy. Okay. Next is governance. When we develop the technology in general, and especially in dental technology, we need to take into account the participatory and adaptive governance. And of course, we need to develop, quality and systemic coherence, which, we need to develop a system to ensure that the quality, the technology that we develop or invent or we apply is, guaranteed. And for that, we need a mechanism of evaluation and adjustment. Okay, ladies and gentlemen, the next question is why we need technology. I think you all have been aware about this, that technology would, improve our medical research, would improve our, service, including diagnosis, treatment, and so on. So we hope that by using technology, we can, get a result in better outcomes and more efficient healthcare system overall. Okay, I think we agreed about this. In the dental area, there are many, research about this, and lately there is a interesting research that is titled "Influence of New Technology in Dental Care: A Public Health Perspective." You can read and you can find it in International Journal of Environmental Research and Public Health. And from that research, we can see that the advent of new technology has caused significant changes in the field of dentistry, enabling oral health professionals to provide more efficient and effective treatments to their patients. So from this research, we can highlight two key words, which are efficient and effective treatments. So when we talk about technology, so we are gonna talk about efficient and effective treatments. Well, and some of the reason why in the dental care we need this technology, because we need more accurate diagnosis, and because sometimes because area of work of us is limited in oral cavity. So when we use conventional or traditional approach, it's full of limitations. So technology would help us, and you know what, maybe in all fields in healthcare, nowadays we are, already familiar with, electronic health record system. So that electronic health record system ensures efficient and secure patient information. Well, ladies and gentlemen, there are 4 most significant development of dental technologies, which are teledentistry, virtual reality, artificial intelligence, and 3D printing. So I hope in the Poltekkes Jakarta one, it should be, developed as well. Well, ladies and gentlemen, because of the time, I think I'm not gonna go into detail. However, I would like to take you guys to, the span of the utilization of the technology. From this slide, we can see that using the technology could be, applied from the management to the, practical, or when we perform our, service. When we talk about diagnostic, we can use X-ray. We can use digital X-ray, and when we do planning for our treatment, there are technologies available on the market using, CAD/CAM systems. And also when we perform the therapy, the trend now is, in the oral health therapy, the therapy we perform should be more, less painful, less invasive, minimum intervention. So there are technologies are available also for that. Okay. And maybe I could show you some example in that matter, For example, for diagnosis or for consultation, we can develop teledentistry or teledental therapy, which, you can find it a lot online, actually. And for example, I would like to show you one video. I hope you guys can hear the voice. And maybe it's more suitable for dental technologists, but what I'm trying to tell you guys that, the technologies now, very advanced, So without, meeting the dentist, patient could have, good, dentures, Okay, without, using study model or something like that, but using this artificial intelligence, a patient could have, a beautiful, dentures. Okay, I'm gonna skip this video. And
in this video, I will cover the
Okay.
simple steps for creating a detailed full-mouth digital impression. I will begin by sitting behind the patient at the 12 o'clock position with the display on my dominant side. This will allow me to have easy access to the display touchscreen and the wand without twisting or turning. After completing the case RX, I'm ready to begin scanning. I'll tap on the scanning sleeve icon at the top of the screen to activate the wand. Waiting 10 seconds after the light turns on allows the tip to defog before I place it in the patient's mouth. Next, I will place the tip of the wand on the occlusal surface of the terminal molar. I'll begin by scanning the entire occlusal of the arch. Being sure to keep the wand flat on the occlusal, I'll steadily bring the wand toward the anterior. When I reach the bicuspid, I'll continue across the anterior, tilting slightly to the lingual, and at the contralateral bicuspid, proceed by moving the tip straight back to the opposing terminal molar. Once I've reached the most terminal tooth, I'll rotate to the lingual. I'll bring the cable end of the wand out to the side, and maintain a 45-degree angle of the wand tip. to the lingual surface. Using a twisting motion, I'll continue around the entire arch, being sure to capture the inner proximal anatomy of the entire lingual surface. After I have completed the lingual, I'll rotate to the buccal.
Okay, I think I'm gonna skip this video and I'm gonna jump to the core of the presentation, which is how to develop the technology in general area, but specifically in the dental area or dental hygiene and dental therapy care. First of all, we need to find an unmet need. So we need to consider that when we apply or when we invent or develop such a new technology, we need to consider the need of the patient and the community. And the second one is we need to have a research, to conduct a research of the effects of the invention or the development of the technology. And for that, we need to gather requirements from the government, from the community. And when we are going to design and plan the community, the technology or the, let's say application, we need to involve the stakeholders, especially the user. And we need to build and deliver the technology, use the clear requirements. That's why, inventing, developing a technology is not really easy. Next one is when we are talking about research, inventing, developing upon a type of technology, we need feedback, and iterate. We need to, trial and error, trial. And after we find, a better technology, we need to make sure that the user will love it. And then we need to, collaborate and cooperate with the stakeholders to launch and to have a partnership with the stakeholders. And the most important is when we develop a technology, in general, in a dental area, we need to develop the technology with the empathy. I think we are already aware about this. Well, for conclusion, when we talk about the development of the technology, we need to educate the students and the health professionals, especially oral health therapists, to master some competencies, which are number one. If we expect a dental hygienist and dental therapist or oral health therapist to, more innovative, so we need to make them master a competency of complex problem solving. And then we need to teach them to be able to coordinate with people. That's why we need to develop a certain competency in people management, critical thinking, negotiation, quality control, service orientation, judgment and decision making, active learning, and creativity. That's the core competency we need to teach our students, teach our colleagues and members of professions. And after that, we can expect that our students, our lecturers, our members of the profession can develop new technology, especially in the dental areas. I think that's all. I hope my presentation would be useful for you guys. Thank you for listening and considering to develop and or apply technology in providing top-notch dental care. I think thank you all, and I give it back to the moderator. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Suara belum terdengar, Bu.
Hello, anybody there?
Yes, Pak Zen. Bu Mumpuni suaranya?
In the center.
Mr. Zaini, I'm afraid we are crossing the praying time. So maybe the participants can hold the questions and we can send it to you later.
Yes, of course.
Okay.
I'm also in hurry to, Jumu'ah prayer as
Okay.
well.
Thank you very much
for
for the
listening.
informative presentation for the session.
Yeah, I hope it would be useful for our students
course,
and our
it's
lecturers
very
and
informative.
all audience as well.
Very useful for us.
Okay, thank you very much. And
Maybe there is a certificate for you.
Yes.
okay, thank you very much.
On behalf of our director.
Thank you. I really
Poltekkes
appreciate
Jakarta
it.
One, we give the great appreciation for you to give the explanation for us and your experience. Please receive the certificate.
Thank you very much, Ibu Mumpuni. Thank you very much, and I really appreciate it.
See you again later.
See you. Bye-bye.
Terima kasih, Pak
Waalaikumsalam
Jaini.
warahmatullahi wabarakatuh.
Terima kasih semuanya.
Ya, Pak.
Bye.
I think that's the end of the second session. Thank you very much for all the participants for your questions and attention. And I give it back to the Master of Ceremony, Miss Anna. Thank you very much. Goodbye.
Thank you very much to Ms. Ni Ketut and Mr. Zaini Dahlan who delivered the presentation really clear, and especially to Mr. Zaini Dahlan, really appreciate your kindness that delivered his presentation just now. And also on behalf of committee, I apologize for your inconvenience that Professor Samar couldn't join at this time. So we hope that in this afternoon session, he could join with us. And then thank you very much to Ms. Mumpuni to become our moderator. And we would like to express our gratitude with handed you a certificate as a moderator. Maybe IT could show the certificate for Ms. Mumpuni. Okay, this one, Mrs. Mumpuni, thank you very much for your participate in moderator for this second session. Thank you. Then, the honorable guest speakers and all participants, we are now going to have lunch break, and please stand by with us even at 1 p.m. at Jakarta time. Thank you, everyone.
Thank you, thank you.
Ella bilang ya. Lucu banget sih.
Wester pasangin dong.
Cek.
Tapi ini masuk ke Zoom. Masuk. Udah masuk. Oke.
Is my voice audible? Ladies and gentlemen, afternoon session will be start shortly. Please be prepared. The honorable guest speakers and all participants, welcome back to International Seminar Polytechnic of Health Science Jakarta 1. We are going to the next agenda. This is presentation from Dr. Ketut Bagus Priambada and continue with presentation from Ms. Suci Anastasia, BSc PO PhD candidate in the Ohio State University from prosthetic orthotic field. That those presentation will be led by Mr. Raden Ahmad Chandra Putra, BPO, MSc. But before that, I ask Master of Ceremony will read the curriculum vitae of Mr. Raden Ahmad Chandra Putra, BPO, MSc. Mr. Raden Ahmad Chandra Putra, BPO MSc is a lecturer at Prosthetic Orthotics Department, Polytechnic Health of Science, Jakarta 1. Mr. Chandra earned master degree of Master Science in Clinical Science International Program, Faculty Medicine of Siriraj, Bangkok, Thailand. He also currently as a Vice President of Institution Education Association of Prosthetics Orthotics Indonesia. Without any further ado, to Mr. Raden Ahmad Chandra, time is yours.
Yes, thank you very much for the introduction, Ms. Anna, as an MC. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen, and welcome back again to the international seminar on the theme Health Aid Technology. I'm Chandra, and I am honored to be your moderator for this important international seminar for session 3. In this session, we will explore the intersection of healthcare and technology, discussing how advancement in technology are transforming the way we provide and receive healthcare around the world. Before we begin, let's go over some important housekeeping matters. Please make sure your mobile phone are on the silent mode. We encourage active participation from the audience, and we will have dedicated Q&A session after presentation from all speakers. So in this session 3, there will be 2 speakers for the last session. We are privileged to have with us a distinguished expert in the field. There will be a presentation session in the field of orthotics and prosthetics technology with 2 speakers. So let me introduce our speakers for this session 3. Please, IT, prepare and show spotlight of Dr. Ketut and Suci's CV. For the first speaker, his name is Dr. Ketut Bagus Priambada. He is a founder of Techno Medica Manufacture, Inovasi, and also he is an intermittent lecturer at the Michigan University. Currently, he is staying in Seattle, USA. His education background, bachelor in mechanical engineering, and he pursue his master and PhD from the Michigan University, same field in mechanical engineering. Currently, he is living in Seattle, USA. Let me greet Dr. Ketut. Hi, Dr. Ketut. How are you?
Good, thank you. Nice to meet you.
Nice to meet you too. Thank you for participating to our seminar. I know it is very late in Seattle. What time is it?
Yeah, I'm actually in Michigan, but yeah, it's 2 a.m. in the morning.
2 a.m. Thank you very much for sparing your time today to be our speaker. It's around 12 hours behind Jakarta time. But hold on, wait a minute. I'm going to introduce the second speaker first before you start a presentation. Is it okay?
Yeah, it's okay, Pak Chandra.
Thank you very much. So let me now introduce of the second speaker for these sessions. She is actually my colleague at the Health Poltekkes Jakarta one. Her name is Suci Anastasia. He is a lecturer of Department Prosthetics and Orthotics, Health Poltekkes Jakarta one. He took a Bachelor of Science in Prosthetics and Orthotics from Kilimanjaro Christian Medical College, Tumaini, Tanzania. She completed her master degree in Human Movement Science from Vrije University, Amsterdam, Netherlands. Currently, she is pursuing PhD in Rehabilitation Science at the Ohio State University. Let me also greet Mrs. Suci. Hi, Suci. How are you? Okay, Suci still have a little bit technical problem. So let me explain how this session will run. So each speaker will be having maximum 40 minutes for the presentations, and we will have a panel discussions after the second speaker, which is Suci's presentations. We also encourage questions from the audience. If you have any questions, please put in the chat box and indicate to which speaker is addressed to. And we will do our best to discuss in the Q&A session. Without further ado, let me welcome Dr. Ketut to present with the topic of state of arts, prosthetics, and current technologies. To Dr. Ketut, time is yours.
Thank you, Pak. Good afternoon, everyone. My name is Ketut Bagus, but you can call me Bagus. I'll be presenting my presentation on the state of the arts, on prosthetic socket and the current technology. I think Pak Chandra already explained a little bit of my background, but let me explain a little more about my project experience. So I'm experienced in multiple parts of the industry. I've been working on automotive and energy, material science, and also mainly in medical sector as well. So in the medical sector, I have some experience with prosthetic and orthotics, and my research, my dissertation research was actually on sensor fabrication for prosthetic socket fitting. Aside from prosthetics, I also have experience on emergency care and also for mask, N95 mask research as well. So I'm actually the founder for Technomedica, and Technomedica is a startup in the medical device sector. We are founded in 2020, and we're located in Semarang. And our focus is on research and development of medical devices. So we heavily invested our time a lot in collaborating with research institution and also the academia sector. We are constantly looking for partners that we can collaborate with on developing medical devices that we can distribute in Indonesia. So yeah, as I said before, we are constantly looking for collaboration. And if you're a research faculty and you have any idea that we can bring to market, we are looking forward to collaborate with you, and we can look for fundings together, and we can distribute the benefits of the research as well. So we can get patents, training, and also get the research result as well that can be useful for the community. So yeah, that's a little bit of a background about me and my company. And for the background, so we know that the loss of lower limb has a profound impact on the mobility of a patient, and the patient sometimes is limited on their ability to perform work, and sometimes they're limited to the type of work that they can do, and sometimes they also cannot work at all. So it's very important for their quality of life. So the prosthetic limb that they have must consider a lot of things other than comfort. They also need to consider the alignment, the biomechanics, the gait. So this is to prevent any discomfort and maintain stability, and also reduce secondary health issues such as ulcers or rash on the skin. So a good prosthetic limb design can greatly influence the individual well-being, the self-esteem, and it's also easier for them to integrate into the social communities. There are a lot of classifications for the lower limb, but we're in this section, we're gonna only focus on transtibial amputation, sockets for transtibial amputation, and transfemoral amputation. Yeah, so the importance of the optimal design is optimal design for prosthetic socket is, first, it serves as the interface between the residual limb and the prosthesis. So it's arguably the most important part of the prosthesis because it connects the prosthesis with the patient. And then the residual limb also came with various shapes, sizes, and contours. And the socket needs to maintain proper contact at all times if possible. And then also the socket must evenly distribute the forces across the residual limb to prevent the ulcer problem or the secondary health issues. Discomfort or pain can significantly affect the user's satisfaction. So sometimes if the user doesn't like how it fits, sometimes the user doesn't want to wear the prosthetics at all. So that can be detrimental to the quality of life. So there are a lot of aspects for prosthetic design factors. There's how you build, what material you use, how you construct the prosthetic socket, and then there are patient-centric design that you need to pay attention because sockets are built usually customized for patients, and they need to pay attention to the design of the contour of the patient's limb. And then you also need to think about pressure relief areas. So there are a process in prosthetic building process that is called rectification. In this rectification process, you need to be aware of how you remove the materials of the model to make sure that you avoid high pressure areas. And then we also have socket alignment. So the socket needs to be aligned perfectly with the pylon and the foot to have a good gait for the patient. So the socket must also have a good adjustability if possible. So because residual limb changes in volume in a day and sometimes also throughout the life cycle of the socket. So if you have a socket that's adjustable, that will be very beneficial. And then you also have the suspension system. So sometimes you can also have a suspension system that will allow you to damp any hard forces that is received by the foot. So in this presentation, we will focus on three aspects: the construction technique, the adjustability, and the suspension system. So the first one is about the suspension system. So this is a technology that was developed by Autobot. It is a vacuum-assisted suspension socket. So in this socket, there is a pump located at the bottom above the feet. So that pump, if the user apply force to the pump, then it will act as a suspension for the user. And it can also provide vacuum that will suck the socket liner. So it can be more, the socket fitting can be more tight. So what is the pros and cons for this? The pros is you have automatic adjustment. So whenever the user steps into the foot, the socket will create a vacuum that will tight the fitting of the socket. And it also creates uniform pressure. And yeah, it also has reliable connections at the foot, and also reliable connection between the liner and the socket. The cons is the weight, because the pump can weigh about 500 grams, and sometimes user doesn't like that extra weight. And then the heat dissipation, because every side of the liner is well insulated. Sometimes the heat dissipation can be a problem, especially for tropical countries. So this is a video about the product.
10,000 steps a day make you happy, they say. It also covers these distances quite buoyantly, thanks to the new dynamic vacuum system from Autobot. We'll now put together.
Can you hear the voice part?
That this meter are excited about.
Yeah, yes, we can hear this voice.
Okay.
Technology systems, of course, the shuttle rocket and lanyard system, as well as the valve and harmony system. These are now supplemented with an innovation, the dynamic vacuum system. To understand what is good about the dynamic vacuums. Function.
And now the voice is going, dismissing.
Into the cylinder chain.
Sorry, Pak.
Agak sedikit kecil suaranya, Pak.
Oh, okay. Let me try to.
Ejected from the cylinder chain. And from fall back in this case. Also, special.
So yeah, let me skip this part. I think the idea is to understand how it works. So let's move to the next technology. So this section of the technology focus on the adjustability of the socket, and this is from a company called iFit. In this socket, you can see that the design of the socket is standardized. So you can select the socket size based on the measurement of your residual limb, and there's no need for casting like conventional socket fabrication process. And and it is also adjustable, but there are some cons to this design. Is the excessive pressure, because it is not customized in shape. Sometimes user that has a different, more irregular shape doesn't fit really well for this type of socket. So it really depends on the type of residual limb that the user has. So short video about iFit.
Sorry, Mr. Bagus, is there any sound of your video?
Yeah, I think there's supposed to be sound. Okay, let me.
The prosthetic socket also extends above the knee and provides for greater stability while ambulating. Patient comfort and stability, however, goes beyond the first visit. Some patients, especially with heart failure and kidney disease, frequently experience fluctuating edema in their legs. With the iFit device, the wearer simply loosens the socket for better comfort. Prosthetists can utilize iFit technology either as an interim measure or as a long-wearing functional prosthetic system. Our goal was to design a product that filled a niche in the prosthetic market. It is compatible with other commercially available feet and suspension systems. This affords a greater customization for the patient and the prosthetist.
So yeah, I think one of the benefits of the technology is you can fit it off the shelf. So when you come to the clinic, the patient can receive the socket and directly use it at the same time. So there's no molding or casting required. Another aspect of adjustability, we want to focus on the adjustability aspect, is the socketless socket. In here we have like a exoskeleton, a socket that only comprised of exoskeleton, and that allows for adjustability as well. But the cons of having this socket is because you only have a few surfaces that is interacting with the socket. Sometimes it can cause excessive pressure. So for this socket, it still requires some customizability. For example, the plate that's located on the back here, it still requires to be molded to the shape of the residual limb. So another example is the infinite socket, similar type of design. It is adjustable. You can see there's 4 pillars that can be adjusted based on the strap tightness. Again, with adjustable socket, you deal with excessive pressure because you only have some surfaces that is connecting to the liner.
I'm sorry, Dr. Bagus. We cannot see the slide change, so still the same with the previous ones. Yeah.
Sorry. Let me restart. Is this okay, Pak?
Yeah, that was okay.
Okay. Okay. So yeah, so this is the infinite socket. Again, let's just see the video. Yeah, so this is how you adjust the socket, just by tightening the straps. Whenever the volume of the residual limb changes, you can just adjust the strap to acquire more comfort. Again, in the adjustability aspect, we have Refo Fit. In this particular socket, you have a few surfaces that is connected with a wire, and then that wire can be adjusted, that wire length can be adjusted, so that allows for a tightening grip. The good part about the socket is you have a full contact between the socket and the liner, so the comfort is preferable at this design. So by adjusting the dial on the back, the surfaces around the socket itself can move towards the middle, therefore tightening the fit of the socket. Okay, again, for the adjustability, we have a socket by Autobox, similar concept. By adjusting the cable system length, you can acquire a tighter fit. That's how you can adjust the fit of the socket. So that ends the presentation on the adjustability aspect. As we can see, a lot of companies are focusing on the adjustability of the socket because they understand that volume change is very critical. And if you have an adjustable socket, you can change the fitting based on the volume change that you're experiencing. So we're going to move forward to the fabrication method. So this one is called the extremity socket. It is built with some kind of a carbon reinforced polymer. So it is supposed to be fabricated quickly. It allows for a one-day visit. So whenever the customer comes, the patient comes, they can receive the prosthesis within a few hours. So we will look a bit more closely on how they can achieve this.
MPTT socket is formed over a positive limb model. Use your preferred casting or scanning method and modification technique to obtain a positive limb model. Remove excessive buildups from around the proximal brim to prevent overstretching of the socket. Maintain a round shape without flattening the posterior wall. Ensure the limb length does not exceed the length of the socket by measuring from the most proximal trim line to the distal end of the limb model. This length should be no more than 29 centimeters. Socket sizing is determined using 3 measurements. First, take a circumferential measurement, 4 centimeters, from the distal end to determine the socket size. Then, use the length measurement from MPT to the distal end and the circumferential measurement at MPT to determine the socket profile per size, as shown here. Move your finished and smooth limb model to the vacuum stand. Add spacers between the model and vacuum stand to ensure the socket will not contact the stand once it's pulled. Then apply a vacuum nylon. Place the socket into the extremity benchtop heating unit and ensure proper alignment on the pedestal. If using size 26 or 26 plus, insert the rubber O-ring around the distal base of the socket and place the lid over the socket base. To begin heating, press the power button to turn the unit on. Press start to accept the temperature, then press start again to accept the time, and start once more to begin heating. The timer will start counting down once the oven reaches the set temperature. Ensure all supplies are laid out next to the vacuum stand. Once the timer alarms, remove the socket from the heating unit by the socket base. Apply powder to the inside of the socket and gently pre-stretch. Identify the posterior seam on the outside of the socket. Ensure correct socket rotational alignment using the posterior seam and the medial and lateral distal base cutouts. Maintaining this alignment, pull the socket down over the model from the proximal end. Use the base plate to push down from the distal end to prevent distal base distortion. Adjust base alignment if needed. Ensure distal contact between the limb model and the socket. Place a piece of tape over the hole in the distal base to create a seal and apply vacuum. Once cool, remove from vacuum and draw trim lines. The extremity TT requires an anterior trim line of 2.5 centimeters proximal to MPT to maximize socket strength and maintain warranty. Trim, remove the socket, and smooth and buff the proximal brim of the socket. Ensure the outer surface of the brim is smooth.
Starting from this process, it's the same as the conventional prosthetic, but at least we can see that the difference between this socket and the conventional carbon fiber socket is this type of socket doesn't require infusion process that accelerate the fabrication process. Okay, there's another technology by Oser. This is called the direct socket. So let's. So as you can see, they apply a customized carbon fiber, a dry carbon fiber leaf, and then in this process right now, they will infuse the carbon fiber directly to the patient's residual limb. So they don't need to fabricate any models, any positive casting anymore. And then they, to make the shape more aligned with the patient surface, they apply pressure through pumping a customized balloon. So this balloon will press the carbon fiber towards the patient's residual limb and provide a better contact. Yep, I guess that's the difference in this process. I think the following process will be similar with any conventional process. So they actually did a study in 2018, I believe, on using the direct socket by OSER in Indonesia, and they found the result of using the socket. So the comfortability between the initial fitting and after 4 to 6 months does not change. So we can see some potential of good comfort that is experienced by the patient by using the socket. And then in terms of the technology for cooling, so we know that the liner, the residual limb inside the socket experience very high heat because it is insulated sometimes by the liner and also by the socket. So it doesn't have any air exchange between the residual limb and the outside air that creates a heating problem. So in this particular technology, there is a thermoelectric cooling that is attached to the socket, and then this thermoelectric cooling will cool the plate inside the socket wall and provide that cooling process between the residual limb and the liner. And then based on this, the case study that has been performed, this technology was able to reduce the temperature compared to the conventional process by 2 degrees Celsius. So it's a pretty significant change, and the patient will be more comfortable because it is cooler. But there are some drawback of using this technology. You need to have the module for the cooler, and that creates the extra weight for the socket. And then lastly, we have the 3D printed socket. This is actually part of the fabrication aspect. What is the benefit of using this type of technology? It's precise and accurate. It's cost saving because it is 3D printed, and sometimes 3D printed material can be cheaper, and it reduced the necessity for labor, and it also can be created in 1-day visit because of the simplicity of the process. The cons of this technology, it is compared to the material with the same density, it is weaker, so it can break easier than the conventional material. And then sometimes it requires additional skills to use the software to design and to operate the 3D printer. So let's see.
That's good. Yep. Just let me sort of control it. Good.
For amputees, sockets are a critical part of any prosthesis, supporting their weight and movement. But they often have to be modified or remade several times if the initial fit isn't right and to adapt to the changing shape of the patient's limb, says physiatrist Dr. Amanda Mayo. It's a multi-step process, each one taking about 8 hours to complete by hand.
So prosthetics is made very manually, like we take manual casts and the process and the technicians have to do a lot of fabrication. So it takes a long time and we're just trying to see if we can make things more efficiently for patients and use 3D printing sort of in the prosthetic space.
That's led to Sunnybrook trialing this, having a 3D printer do the work, creating a digital model of the patient's leg from a computerized scan using a handheld tablet. Sean Fitzpatrick became an amputee following a motorcycle collision last year. He says the traditional manual casting method has its drawbacks.
It's a whole week before you get it, and a whole week mightn't seem much, but for somebody that's learned how to walk and everything, it's pretty significant.
He says it would be great for patients to have another option.
So I hope 3D printing, once it scans your whole leg, that's your leg. And hope that slides on and it fits like a glove.
Dr. Mayo says there are a lot of people who are building prosthetics, but Sunnybrook is the first to study how safe, effective, and patient-friendly 3D printing is. For now, the focus is on testing the technology on patients with lower extremity limb loss. If successful, it could offer prosthetists one more tool to work with and skills around what could very well be the technology shaping the future of their field. With Sunnyview, I'm Monica Mattis.
So yeah, another case study that we have on 3D printed prosthetic socket is actually a project that my company is involved with several universities such as IPB and UNUSIA, and we are currently active in a project called Cyber Physical System for prosthetic socket fabrication. So we know that the conventional prosthetic socket fabrication is time consuming and labor intensive. So we want to try to minimize that process and processing time and cost by using cyber physical system manufacturing system. So we know that the prosthetic socket costs more than 7 million, depending on transtibial or transfemoral, but usually the cheapest range is about 7 million rupiah. And then sometimes because of the incorrect fitting, the patient needs to revisit the clinic up to 3 times. And then the times that is required for the patient to receive the final product usually ranges before about 28 to 56 days based on our interview with the local clinic in Indonesia. So the objective is to create a faster, easier production process, and then to minimize the number of patient visits and create an accurate enough socket that doesn't require a refitting process. So the technology that we utilize is the cyber physical system. So we utilize 3D printing technology along with 3D scanner and IoT technology to build this digital manufacturing system. And then the other technology that we want to focus is on accessible scanning technology. So if usually for prosthetic purposes, the scanner can cost about more than $10,000. But we were in this project, we want to focus on using low-cost scanning technology, such as using a smartphone. And then the other technology that we want to focus is using a low-cost 3D printer that is commercially available and accessible to everyone. So this is the general direction of the process. We have software design, and then we convert it into an STL or a file that we need for the 3D printer. And then once it is 3D printed, we can assemble it and fit it to the patient. The proposition is to make the socket itself affordable, around 2 million rupiah. And then we also want to make it accurate because it is directly following the surface of the patient's residual limb. And then we want to make the system fast enough, less than 24 hours from scanning to delivery. And also, yeah, we want to achieve the 1-day visit. So the project progress so far is we finished the design of the prototype, and then we also designed some adapter that we can use for the socket. And we also started with measuring the patient's residual limb. So this is to fit to know what silicone liner sizes that they need during the scanning process. And then once we know the exact size of the silicone liner, we apply the silicone liner, and then we scan it using the mobile phone. So the next step is to design and fabricate the socket. And also, as for the validation process, we will use the ISO 10328 this is a strength testing standard for prosthetics. So we use this for validating if the socket is strong enough compared to the conventional socket. And then we also will perform a patient quality of care survey to make sure that the patient is satisfied with the socket. So that ends my presentation. I don't know if we have time for questions. Sorry for taking so long for the presentation, Pak Chandra.
Okay, thank you very much for your very comprehensive presentation, especially to develop technology in fabricating prosthesis device. Maybe you can have a break first, and we will have a discussion after sessions for the second one for the sessions. So let me greet Mrs. Suchi first. Miss Suchi, are you here with us?
Yes, I'm here. Am I audible for you?
Yes, very clear. How are you?
I'm good. How are you?
Happy birthday anyway.
Thank you.
Selamat ulang tahun, Mbak Uci.
Makasih Bu Suryani.
Happy birthday.
Makasih Bu Ria. Thank you everyone.
Okay, so wait a minute. I would like to remind to all audience, if you have any question, please put in the chat box and indicate to which speaker is addressed to. And we will do our best to discuss in Q&A sessions. So let me welcome Ms. Suchi and Natasha to present with the topic of fabrications jointed AFO using the local prototype orthotic ankle joint. To Mrs. Suchi, the time is yours.
Oke, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Okay. So I hope I'm audible enough for all of you. First of all, good afternoon, everyone. Thank you very much for the organizing committee to invite me representing my team, research team, to present our research. And also thank you for Professor Marsum and all the management and Poltekkes Kemenkes Jakarta for this opportunity. We are really happy to have this opportunity to share and disseminate our research about the prototype of local orthotic ankle joint. So let me first share my screen. I'm so sorry. Okay. So someone helped with the screen. That's very nice. Okay. So this is like the. Okay. Is it me to share or someone will have? I think it's better for me to share. Okay.
So which one that is more convenient for you? Is that okay?
I think it's okay.
All right.
If someone can help. So today, like we are not going to discuss about like the development of the prototype because we already disseminated this part last year in the same event from the Center of Excellence of the Poltekkes Health Sciences Jakarta. So like today we are going to more focus on like the fabrication of the local prototype orthotic ankle joint of that the one that we developed, because we think it's also important to share it, especially to all the prosthetists and orthotists that are in Indonesia who maybe like attend this meeting, or even like at least the Department of Orthotic Prosthetic, or we so-called GSPO. So next. So this is like our research team who developed this prototype. It consists of the lecturer and also students from and graduates from the GSPO, or as we know as the School of Prosthetics and Orthotic of Poltekkes Health Sciences Jakarta 1. Next. I'm just going to give the overview, like to remind everyone about what is this research is all about. So this orthotic ankle joint is developed to help provide a solution, alternative solution for to improve the gait pattern in patient with drop foot by using like the jointed AFO. So maybe if the video can be played, like as we can see. Yeah, maybe the sound can be reduced. Or so here, like people with the foot drop, like when they walk, they tend to really like have like risk to stumble, or because of there's no toe clearance. So with the help of this jointed AFO, it helps the drop foot to be well accommodated, and then it provides like an improved gait pattern. And to make this jointed AFO, we need this orthotic ankle joint, the one in the red circles. And this ankle joint is in Indonesia is still imported, as we don't have any company that produce this component locally in Indonesia. Next, maybe we can see in the next slide. So this orthotic ankle joint, the one that we discussed, like it has like a increase in cost because of it's imported. So the tax and the custom from the import made the component to be expensive, and therefore to fabricate the jointed AFO, because like we need this component to really fabricate. As we can see, this component is the one that connected the upper part or the shank part of the limbs of the lower limbs with the foot part. So this ankle give or mimic the motion of the ankle, the plantar flexion and dorsiflexion, as we can see from the video before. And this component, a very simple component, but fun fact, in Indonesia, it's still imported and there's no company who produce it yet. So we think our team to develop the prototype one next. The prototype one that are locally available. That means it's local, not LOLO. Sorry for the typo. So it's like a local prototype by using 3D printing mechanism that are really like now has been emerged, like an emerging technology since I think 10 years ago, but it was used or utilized for another purpose, like maybe to print like a part of a mechanical part of like a machine or something else, but it never used in developing like orthotics components. So we think with this emerging technology that is like really accessible now in Indonesia, we can think of maybe we can make like a orthotic component for this jointed AFO out of this 3D printing. And we collaborated with the mechanical engineering faculty of Institute Teknologi Bandung, and then also mechanical engineering faculty of University of Indonesia. We collaborate as we ask for their expertise, because like we don't have we really need the advice in the engineering part, like in the design part, and we discuss with them, and then having like a focus group discussion in how to develop like ankle joint, and then we use the knowledge and the input and the feedback from our collaborator in developing this design. So initially we had like 4 design, a proposed design, 4 of them, and then through the static analysis, like with not like in the lab, but with the simulation software, we analyzed this ankle joint, and then the design number 3, the one that we can see in the picture in the middle, is the one that have the most similar properties, mechanical properties, with the gold standard. So we use the gold standard from with the type of the flexible orthotic ankle joint, and then this was our reference as a gold standard to develop our design. And then we hope that this design could have the same or similar mechanical properties with the gold standard. And when we have this design, the number 3, then we also did a literature review about the materials, the possible materials that could be possible. We make for the 3D printing machine. We print with the 3D printing machine, and we did like a very extensive literature review about the elastomers groups, which is like there's a lot of them, and out of those groups, like we propose like I think LGPE, PP, and then ABA, and then PLA, and then and nylon and polyurethane, and then the result of the static analysis also have that the materials number 3 could be possible to be printed with having the similar properties with the gold standard is with nylon and the polyurethane. So that's how we develop and print. In the picture in the right bottom, we can see the 2 of them, like one is white and the other one is like cream in color. The white one is the polyurethane prototype ankle joint, and then the cream one is a nylon prototype ankle joint. Next. Okay. So I'm going to explain like the manufacture process of the local prototype orthotic ankle joint. And for this one is the design that because in jointed AFO, it has many designs, like they have like a free dorsiflexion and plantar flexion, and then they have like a low dorsi and plantar stop design, and this one is the one that are specifically designed for patients with the foot drop, which is the low dorsiflexion and plantar stop design. Next. Okay, so the first part we start, it's very similar with like the way we fabricate the jointed A4 with using the gold standard orthotic ankle joint. And it's started from the casting, or we in order to make a negative cast, so we use like first of all, I would like to explain that the one this preliminary clinical trial was conducted with using the able-bodied, not with the patient, because The first reason because we would like to see how feasible it is in the able-bodied, and then if it's feasible, then maybe we can try it with the real patient. And the second one is because it's during COVID also, and there was a lockdown period that time when we did this clinical trial. So the lockdown also hinder us to really connect it with the patient, right? So we think that we need to still like moving forward with our research, because we started this research since 2019 about the development of the design up until we have like the real orthotic component, and then that's why we just decided like why we don't start like the preliminary clinical trial with the able-bodied during the COVID-19, and we used participants is were the able-bodied. So this is like we need to make a negative cast when we really mold from the limb of the patient, because it's a custom-made jointed AFO. It's not a prefabricated one or off-the-shelf one. So we really customly made them based on their own anatomical morphology. So this going to be the same when we are going to do it with the patient in the future. We really going to need to cast from the patient itself. Maybe it's similar with what Pak Bagus just demonstrated previously about like how we cast the limb of the patient, like from the patient to get the individual morphology and anatomical landmarks. So we make like we make the landmark first, and then we cast with the POP bandage. We still use the conventional way of it with the POP bandage, and then afterwards like we continue with the filling this negative cast to get the positive mold. Next. So in the next slide, we're going to see like how this negative cast will be filled with the POP powder to get the positive one. Can we go back? I think this one is like too further. Okay, so this is like the process of filling the negative cast, like the POP powder first mixtured with the water with certain ratio, and then we fill the negative to get the positive mold, and this positive mold was aimed for us to make all the rectification or the modification, because we really need to modify this positive mold with the considering all the biomechanical principles, like there's an area which is like intolerant to pressure, so we need to build it up. Next, we can see in the next part, so we need to build up in that area, and then also we need also to build up at the malleoli area, because of later on there's going to be a placement of the dummy of the ankle joint in that part, right? And then also this rectification process serve as a step where we are going to place our orthotic ankle joint. So in this prototype, we use for the joint placement method, we use for the nylon material, we use the anatomical mechanical system, because the nylon material is more rigid. So we need really the congruency between these two joints, the one because it comes in pairs, right? To be placed in medial part of the malleoli, and then in the lateral part of the other malleolus. So this lateral and medial malleoli need to be congruent because the nylon material is more rigid. So if we don't have this congruency, it will create like a moment, a torsion moment, and it might make the joint to be distracted soon. So in order to diminish that possibility, therefore, or that moment, therefore we need to make the both joint to be congruent, but differently with the one of the PU, because like we fabricate and we did the clinical trial for both local prototype with the nylon and then with the polyurethane. For the PU, we use the principle of anatomical joint placement, where we just follow where the anatomical position of the both malleoli, lateral and the medial, and then we just put them at the tip of the medial and lateral. And this method is the same principle applied in fabricating the gold standard, because the gold standard has the gold standard we use as our reference was the one with the type of the flexible orthotic ankle joint. So it's kind of flexible, so it can really accommodate like that moment occurs because our anatomical ankle joint, they're not congruent. So that can still be tolerable by the flexible mechanical properties of the material of the polyurethane. And then the other remarks that need to be paid attention of is the buildup at the malleoli need to be more than the gold standard one because of the nature of the bolt and nuts, the local bolt and nuts that we are using. For the gold standard, they come the whole package with the bolt and nuts and the spacer and the dummy and everything. But this local prototype, we really try to make everything locally available. So we for the bolt and nut, we just use like the normal bolt and nut with the diameter of 5 millimeter, and then for the spacer we just use like the EVA. And for the dummy, I'm going to explain about the dummy later on in the fabrication section. But basically, in this rectification area, we really need to build up at the malleoli area more than the gold standard, because of the nature of the bolt and nuts in the local is they're very big. So it really, if we don't build it up, it really gonna press, and it's going maybe not to be comfortable for the user to use it if the joint is having like a friction or maybe touching the skin of the patient. Next. Okay, so the next part is like we need to drape this orthotic ankle joint, and normally in the gold standard, it has a dummy there, like to be placed in this positive mold, and then this positive mold will be draped with polypropylene plastic with using the oven that are with the certain heat. And because of the heat of the oven, the plastic melted, right? And then it was like maybe around like 180 to 220 degree of Celsius. That's why the dummy is needed here, because like dummy needs to make like that mold of the shape of the joint to be placed later on when we continue to fabricate the jointed A4. But for our case, the 3D printing doesn't have the material that are required to make the dummy, because like in the gold standard, the dummy normally made out of rubber, but in the 3D printing that are available in Indonesia, it's not compatible yet with the rubber filament of the material to print this joint. So we couldn't make like a dummy that can withstand the certain degree without having deformed after when it interact with the heat. So, but we managed to apply special technique to overcome this issue, and it was successful, fortunately. So for making to drape this A4 in this, like we use the oven, and then like here in the middle up is like when the plastic still really hot, and as we can see the color was clear. And then in the bottom is when it's already getting cold, and then become a plastic again, and cannot be deformed because like it's already hard. And then here's like the A4 that were made out of the prototype nylon and the polyurethane, and I believe also there's the gold standard here, because like when we did the clinical trial, we observe or we investigate the gait parameters of participant wearing the gold standard and then wearing the prototype with the nylon material, and also the prototype with the polyurethane material. Next. Okay, so basically this is like the fabrication after we mold. We get the mold of the plastic. So here, like we open first the plastic with the one that it still has the positive mold inside, and then we chip out all those positive mold material, and then after that we determine the placement of the joint that will be that will be separated to be two, to be the upper part and the lower part, as we can see it in the most left bottom picture, where we can decide it where we are going to separate them. And then we also reinforce like the joint placement, the one from the mold from the dummy. And then here's like we need to make them apart into two, and then now we only have like the foot part and then also the upper part. And in the foot part we need to make like the hole for placement of the bolt and nuts to place the joint. And then also in the right top picture, that one is like we need to make a drill at the posterior part for the plantar stop. We need and then also to put like a bolt there to control the angle of the dorsiflexion that we are going to need later on during the dynamic alignment. So people normally need like 5 to 7 degree of dorsiflexion, but people are different, like each individual are different, like they might need 5 degrees, some might need maybe 3 degree, or maybe some need maybe 7 degree. So by having that bolt at the back, it can help also to control like the amount of the dorsiflexion, apart from the one the opening at the trimline opening at the anterior also. So this both like helping in setting up the angle of the angle of the A4. Next. So here's like we connected now the part of the foot part with the shank part, and then we prepare like this one is like prepare the strap, like the strap is needed for securing the A4 to to the participants' limbs. Next. Okay, so here's like where we need to connect them into two, and then that one is like, as we all can see, there's a movement of like dorsi and plantar flexion at the most right section of the picture or the video. Next. Okay, so this was like again like only as a reminder. We're not going to discuss a lot because like we already discussed about this thing last year, but here's like all those jointed AFO that were fabricated out of the gold standard, and then nylon, and then also the polyurethane. We tested with the participant and then observed their gait parameters like step length, walking speed, cadence, and then step width. And then by using the three, so one participant will walk with three conditions. First with the gold standard jointed AFO, and then the second condition is with the nylon local prototype, and then the third one is with the polyurethane local prototype. And then they were asked to walk like in that 2-meter walking test we did, because like Indonesia is like developing countries. We don't have, not every part of Indonesia has like good facilities and a good and resourceful facilities. So we can do the gait parameters investigation by using the gait lab, but not every setting in Indonesia has the gait lab. So this one we perform it the way with an affordable way, because like the AFO itself has the idea of an affordable method. Therefore, also to the outcome measures, we also use an affordable method also to measure the gait parameters. And then the strap here that I was talking about is to secure like the one at the proximal part of the foot, as you see when I try to don this AFO to the participants, and then here's like the participant walls, and then we investigated their gait parameters. Next. So in the next slide, we can see participant walk with the gold standard. That one is with the gold standard. And then the other one is with the nylon, and then the bottom one at the right section with the polyurethane. So here we can see by inspection with our bare eyes, is like they walk like similar. And again, if we can remind about our result, like the result is really similar. Even the polyurethane local prototype walk faster than the gold standard one. Okay, next. And the research output was like we managed to claim the copyright of the design, and right now we are in the process to claim for the patent of the design of this orthotic ankle joint, but it's still on progress. Next. The limitation of this study, because of like the limited resources and the facilities in Poltekkes Health Sciences Jakarta. For instance, like we don't have the 3D printing machine, so we really need to find another third party that have this 3D printing, but it was not like a big deal, because like it's really easily to be found. Like for our case, we use the 3D printing service from the e-commerce, because like as I said previously, this 3D printing has emerged since years ago, but it was used for other purpose, but never been used in orthotic. I'm not sure, like to our knowledge, to be used in orthotic ankle joint. It's like in this our research, but maybe used in another technology of making orthotic component, or even like prosthetic, like the one of the Pak Bagus just presented, like making the socket out of the 3D printing machine. But in terms of specifically of the orthotic ankle joint to make the A4, to our knowledge, that has not been done yet before. And for the another limitation is due to the small number of the participants due to the lockdown period. And we wish in the future study next that this study can be continued with the clinical trial with a larger scale of the number of the participants, and including also the foot drop patient in the study. And also we would like to do like the study on the feasibility and reliability of this local prototype ankle joint, where it can be reproduced or replicated by another researchers or another clinicians, like with the same outcome. Like they can fabricate the A4 by using the prototype ankle joint successfully. And then we also hope that there's a collaboration across discipline and institution, or even with the industry. And the next part is like the publications and the patent. I think that's all from our research team. Thank you very much for your attention, and you're more than welcome for any questions. I think I'm gonna give the floor back to our moderator. Thank you very much.
Good. Am I audible? Okay, thank you very much. Thank you very much for Ms. Uchi. Very nice presentations, especially in promoting developmental local component, right? Even though that is very simple, but still not available now in Indonesia. So I think it is encouraged to all of prosthetists and orthotists in Indonesia to develop this kind of things, so that we can use more locally available component rather than importing the materials. Thank you very much. Now we are going to discussion session. I would like to remind to all audience, if you have any question, please put in the chat box, or you can just unmute the audio and talk directly with all our speakers today. Please, if you have any questions, you can raise your hands from the Zooms and maybe put in the chat box. Dr. Ketut, are you still here with us?
Yes, Pak Chandra, I'm here.
Okay. Maybe I can start with the question first. So from your presentation related the 3D printings and making a socket, a prosthesis socket for transtibial amputations, may I know what material did you use for it? And then, as I understand, like the 3D printed material, like a PLA GPU, is not really strong enough for apply within weight bearing, as we know that the transtibial user might put a lot of weight bearing in it through the socket, right? As the transverse weight bearing will come from the socket itself into the component. So any consideration in choosing material for the 3D printing?
Yeah, so for the material side, we partnered with IPB, Institute Pertanian Bogor, and they focus on the material aspect for the socket. So we have a few materials that we're testing. It is one of the concerns, because the strength of the 3D printed socket is the biggest consideration that people think about whenever they want to adopt this into their practice. So the standard material that we use is PETG. This is a very well-known material for socket fabrication. A lot of clinics in the US have used this type of material for their 3D printed socket. So this is very standard. But we also want to try some other materials with more I guess exotic because it is not used more frequently. So we want to use nylon material and also carbon PLA infused with carbon fiber. So hopefully we can increase the strength using this type of material.
Right. Thank you very much for your answer. I think it's quite clear. There is a question from the floor from Mrs. Siva. Hi Pak Bagus, Ibu Suci, may I ask you both questions? What is the most challenging part you have experienced during the process of making the device? What is the most challenging part? I think this is a question for both of you. Maybe we can start with Pak Bagus first, then follow up by Ms. Suci.
Yeah, I think for the prosthetic socket fabrication, the most challenging part is the design part, because once we generate the design, we can directly transfer the data to the 3D printer and you can directly print the product. So the design aspect is the process that is still include manual labor, but it's not as intensive as the conventional process, but it does require some labor, and the skill that is required for the design is usually not readily available, at least with the current state of the prosthetic clinic, because usually prosthetic clinics, they're not specializing in mechanical design, and this is also the type of skills that is required. And we're not saying that it's going to be difficult, but it does require some practice to know how to operate the software and to design using the mechanical design software.
So that's why I think the collaboration is very important, right?
Yes, right.
In a part of clinic and also engineering. Ms. Suci, do you want to have any idea about the experience and challenge?
Okay, thank you for the question. I think the most part, I think for like the development of the design of the orthotic component itself was not as much as challenging as when we figured out when to fabricate it to make it feasible to be a jointed A4 as a device, because like the orthotic component itself, it doesn't mean anything in our field, but it's going to be meaningful when it's already become a jointed A4, right? So like the most challenging part was like how to transform and translate this prototype into the jointed A4, like as I mentioned before, like that we didn't have dummy for it, like because we couldn't find any 3D printing that has a rubber filament, but eventually like we managed to find the technique, which I could not really explain here yet, because like we are still under process of the patent. Maybe after we get the patent, we can really share in the manual, because the manual itself is also included in our patent claim. So basically, like what I can just explain is that no dummy was very challenging, because like that is really important to make like really the shape of the joint. But fortunately, we could figure it out. So I think that's the problem. And then maybe the other challenge is like about the limited budget and the facilities. Like it was not easy to conduct this research, especially the clinical trial was performed or conducted during the COVID period in 2021 to 2022. So I think that was also like a challenge, but it's like non-technical related challenge. So I hope it answers your question, Ms. Siva. Thank you.
I think budget is always be a challenge for every research, right? And how I just curious actually from the dummy, as we know that of course the material for the 3D printed will be like the melting point at probably 50, 70 to 80 degrees of Celsius, while when you draping it will be 180 degrees Celsius, it will be melted anyway. Would you have any plan to develop the dummy itself next time through the 3D printed fabrication method?
Yeah, that's a really good question, Pak Chandra. So I think this is like a place for us to really exchange idea and then open for the opportunity for the collaboration due to this scientific forum. And since here we have Pak Bagus, which is like from the engineering part of the world, and we are from the medical part of the world of this, like actually like we are like engineer, orthopedic engineer, but we don't have as much as understanding and expertise in this material part. So maybe we can do collaboration with Pak Bagus like Technomedica to really develop like for the dummy, because like to our very limited understanding in engineering part, like rubber is the one that can withstand like the heat that produced by during the fabrication of the AFO. But the challenge was like we couldn't find any 3D printing in Indonesia that has this filament. So maybe if we could have discussion aside of this in order like maybe to talk about the dummy. But anyway, like for now, with the technique that we found that that we applied during our fabrication, it's I think for now it's a good initial step, because like it's still feasible, like the jointed AFO still managed to be worn by the participant and then walk with it with the very similar or even faster walking speed, if we talk about the walking speed parameter, than the gold standard. So for now, I think we still fine, but it's a good idea also to think about like the dummy, so that we can really ensure that this jointed AFO was made appropriately and be replicated by any orthotist across Indonesia or even maybe across developing countries.
Okay, thank you very much for your answer. So there's a question, Pak Bagus, I think from our next speaker, Bu Suci. Would you like to ask directly, or? Okay, I'll just read it. If possible, would you please explain the total cost to make this innovative prosthesis, the one that you had project previously, and any consideration on by the weight range of prosthetics users of this technology? Thank you.
Yeah, so if we're talking about the price, so we are working with local prosthetic clinics in Sragen and Jakarta, and they help us to provide some quote on the prosthetic socket price, but this is only for research purposes, so I don't think they're making much profit. And we did receive a quote about 2 million rupiah in the socket price. So that is our benchmark because we're only developing the socket, and everything else other than the socket is going to be the same. So that will be the benchmark, and it is probably could be higher than this price. So for our cost for the socket itself, we haven't really calculated the total cost because we need to understand how long the labor time is, so to calculate the labor cost. But at least from the cost of the material itself, it only costs about 300,000 rupiah to 500,000 rupiah, and I think everything else will be counted cost. So if we assume that the labor time is about 1 hour or 2 hours, so I don't think it's going to add very significant cost to the total cost of the socket. So yeah, hopefully we don't have a clear idea on we're hoping that we can minimize this cost so everyone can adopt this type of practice to minimize their prosthetic socket cost. For the consideration for the body range, I think Bu Suci are already aware with classification for prosthetic patient. So depending on like their weight and then their height, they are classified. I don't remember exactly, but we are using the very average of Indonesian. So that is how we choose our patient for the test. And then the design of the socket as well is we do mechanical simulation, we do finite element analysis depending on the weight of the patient, and we are only testing for patients that are within, I believe, 70 kilograms of weight, but it could be higher. So I think depending on the weight, it could affect like how thick your material requirement is. So additional studies are required to try to predict what is the required design for patients that are heavier than our current patient.
Right. Is there any follow-up question from Ms. Suci or just okay?
I think that's okay for now. Thank you.
Okay. Any other questions from the floor? Okay. Miss Anna have a questions? Please.
Okay. Thank you very much, Mr. Ketut Bagus and Miss Suci Anastasia. Happy birthday, Miss Suci. Okay. Mr. Ketut, I want to ask a question regarding your presentation about the socket that have a volume changing for the patients with volume changing, right? So as we know that volume changing of the stem, it will be like variation of the like how much it will be changed, right? For example, in the morning, the patient have like 28, and then in the afternoon have if more than 5 or 10, and it will be different with the other patients as well. So how what can we like measure how long that we can give the how to say like adjustable volume of the patient, the first question, and then the second one, because we will allow the patient to adjust, right? And how can we ask the patient or inform to the patient like when the patient can adjust it, and then in which correct position that we can adjust of the adjustable volume itself. And then may I have a question also directly to Ms. Suci?
Of course.
Okay, thank you, Ms. Suci, for your great presentation. Unfortunately, during your research, I think I'm not here or maybe I missed this point. So I want to ask Ms. Suci for your research. Then when you did tying child to able body, is there any such inclusion criteria, for example, for the able body itself, whether the patient needs to have body weight, in which body weight, and then about the position or problem with the ankle joint, for example, something like that. So thank you very much. That's all for my question.
Okay, can be answered directly. Start from Pak Bagus.
Yeah, thank you for the question, Bu. I'm not a prosthetist, so I don't know the best answer for this, but this is from my general knowledge. I think the way that the patient can do the changes and modification, the adjustment is basically based on their comfortability. So during the feeding process, they will ask the doctor and how tight that they want to have the socket. That really depends on the patient's comfortability. So I think this is a process where the patient and the doctor and the clinician needs to discuss and what is the adjustment that is safe for the patient. Sometimes the patient can also have neuropathy where they don't have any feelings on the residual limb. So that becomes a problem because the patient no longer knows if they're fitting the socket well. So I think in that case, the doctor needs to give some safety range when the patient can only turn, like, let's say, adjust until this tightness. So because of that reason, I think that's the best way to do the adjustment. And I think some doctors, because the volume change usually happens when people are experiencing activities. So usually probably the best way to adjust the residual limb is whenever they finish these activities, when they're walking like very far or running or doing exercise. I think the volume will change dramatically during this process.
Okay, thank you, Mr. Ketut. So, how about the buckle, like the length? How much usually like we give the adjustable volume?
Yeah. So this is my experience not with prosthetic socket, but with using a TLSO. So in TLSO you also have like the tightness, and usually the prosthetists they give a mark on how tight that the strap should be. I think it's going to be a similar process with the socket as well. So the prosthetist can recommend how many turns that the socket needs to be tightened.
Okay, thank you.
Okay, is that enough, Ms. Anna?
Yeah.
Okay, maybe can directly answered by Ms. Suchi for the follow-up questions.
Yeah, thank you, Miss Anna, for your great question. So, for what was the first question? The body weight, right?
The
Inclusion criteria.
Okay, inclusion criteria. Okay, so for the inclusion criteria for this, our participant is the first, the body weight. The body weight range is not more than 75 kg, because when we develop our design, prototype design, we and did the finite element analysis on this component, we included the 75 kg, and then also to develop the ankle joint, this orthotic ankle joint, we counted that weight as our factor of safety to create this component. And why 75 kg? Because it's the average anthropometry of Asian. Because we couldn't find Indonesia specifically, because like in Indonesia, like there's a really less investigated about related with the PO field and orthopedic field, right? So it's like we used Asian anthropometry for that, and then 75 kg was the average for the Asian. And for the inclusive criteria for our participant, like first, they don't have any neurological or musculoskeletal problem, because it will affect their gait parameters if they do have. And then the second one, they understand the instruction, because like when we did the gait parameters, there's a instruction involved in that one. So it's like they has to be understand the instructions. So that means they have a good cognitive skill or cognitive ability. And then also they don't have any problem with the ankle joint, like either it's like a contracture at ankle joint or any neuromusculoskeletal that affect their ankle, especially their ankle joint or the lower limb per se. So I think those three main inclusive criteria in for our participant, and of course also the body weight was within the range of our thing. I hope it answers your question. Thank you.
Thank you, Ms. Uchi. It's clear enough.
And then maybe I will have the last question for Mr. Bagus regarding your past project in design and fabrication of three-axial force sensor for prosthetics and robotic application. I'm just curious about that project. And would it be possible in the future to implement to use your kind of project, your finding from that project in Indonesia, especially as we know that the cause of the amputation was shifting probably previously from the trauma as a number one. Now it is going to be more in peripheral vascular disease, including diabetics. So the pressure distribution that we apply to a socket is a really important to prevent the re-amputated again and to unpleasant pressure because the sensory problem that might happen to the diabetic patients. Would it be possible and feasible to be used in a clinical setting from your project that you have developed previously?
Yeah, thank you for the question, Pak Chandra. So the main focus of the project for the triaxial sensor is not to only detect normal pressure, which we can already do with using off-the-shelf sensor. I think there's a company called TechScan that can detect normal pressure. The biggest problem that people have with prosthetic socket is shear force. It's not the normal force, especially when they're walking. Depending on how fast they walk and the weight of the patient, the patient will experience shear on the skin that will cause that additional health problems like ulcers or skin degradation. So yeah, that the project was focused towards measuring shear, and our current challenge right now is the response from the sensor is not fast enough to detect the changes when the patient is walking. So let's say the patient is walking at a speed of 2 hertz, so about 2 steps per second. So the sensor is not responsive enough to measure that, but this is not because of the limitation in the design of the sensor, but it is on the material side because we are relying on soft material for the sensor, and then soft material is exposed to viscoelastic effect. So that viscoelastic effect causes the delay in the response of the sensor. But we are hoping that we can try to calibrate this delay using machine learning and machine learning methods, so we can try to get a better approximation of the sensor when the patient is walking. If the sensor were to be used only when the patient is standing, it's fine because the response is static, but when it's walking or running even, that's still is challenging for any type of sensor for sockets.
Okay, I think when we evaluate the socket fit would be mostly in the static position.
Yeah, for that it's fine. Yeah.
It's fine in the static position. Okay, maybe we can further collaborate in regards to that part and making probably sock prosthetic stem sock with a sensor to detect the pressure pressures, so that we can evaluate whether we put the pressure correctly or not in our socket. I think that's all. Conclude our presentation of today. Thank you very much for all your active participations and insightful discussion today. And the team Health Aid Technology in the part of prosthetics and orthotics technology is one of the critical important, and we hope that the knowledge share here will lead to the innovative solution for the future. I would like to thanks to all of the speakers, and all of you making this event success. Please accept this certificate from the committees for Dr. Ketut Bagus Priambada.
Thank you, Pak.
You're welcome. And the next certificate will be delivered to Mrs. Suci Anastasia, BSc PO MSc. Please accept the certificate on behalf of the committee.
Thank you, Pak Chandra.
Thank you very much. See you again next time. And good morning to you all from the USA.
Terima kasih Mbak Uci.
Terima
Sama-sama,
kasih
Bu
Mbak
Suryani.
Suci, terima kasih Pak Bagus.
Terima kasih, Pak Chandra.
Yeah, on behalf of the organizing committee, I extend our heartfelt gratitude to all speakers and attendees who made this seminar successfully, and we look forward to seeing you in the future events and working together to harness the power of health aid technology for a better world. Thank you and have a wonderful day. Wassalamualaikum warahmatullahi wabarakatuh. I giving back to MC.
Waalaikumsalam warahmatullahi wabarakatuh.
Wabarakatuh. Thank you very much once again to Dr. Ketut Bagus and Ms. Suci Anastasia, who delivered the amazing presentation and really clear for this afternoon session. And then we would like to thank you very much as well to Mr. Raden Chandra to become our moderator. We would like to express our gratitude with handed you a certificate as moderator. Thank you very much, Mr.
Thank you.
Chandra.
Thank you very much for having me as a moderator today.
Thank you. Excellencies, participants, ladies and gentlemen, we are now going to the end agenda for today. Before we going to close today's agenda, I'd like to remind all of you to fulfill the evaluation form and then make sure the email that you put and name is correctly, because we directly send your certificate through your email that you put on your evaluation form. And that evaluation form also will be as attendance list. Okay, and please turn on the camera before we close, because we would like to take some documentation. There are about some layers. Please open your camera. Okay, I will count. 1, 2, 3. The second layer. 1, 2, 3. The third layer. Okay, 1, 2, 3. Okay, thank you very much. Ladies and gentlemen, here are all the agenda which had been held today. Hopefully, our program will give us some advantage and benefit for our future till we become good people and to do good things. I am Ana Silmia. As Master of Ceremony, beg your apology for my mistake and fault from the beginning till the end. Thank you very much for your attention in joining this program. The honorable guests may leave the room. See you for the next seminar. Thank you.
Thank you, Ms. Anna.
Thank you very much, everyone.
Okay.
Yay.